Good afternoon, everyone. Can everyone hear me? Great. All right. Well, I hope you enjoy your lunch, and I'm hoping to share with you a little bit about myself and a little bit about the topic of cardiology. So just a little bit about myself. I'm originally from the state of New Jersey. I know, I've heard the jokes. I don't need to hear them now. I did my advanced training in electrophysiology over at Cornell in New York City at the New York Presbyterian Hospital. I'm essentially an electrician for the heart, and so I will be talking to you about electrical issues with the heart and some of the topics that pertain to many of my patients. I went from Cornell, and like all things in New York, a big move is measured in blocks, not miles. So I moved 5 blocks up north and practiced at Lenox Hill Hospital for 5 years, and where I directed the complex ablation program. So you may be wondering what caused me to make my move down to Jacksonville. Well, it was this, okay? I couldn't do it anymore. I had 5 feet of snow on both sides of my driveway, and I said, enough is enough. And so I came down to warm Jacksonville, and I haven't looked back since. So what we're going to be covering today is going to be a journey. It's going to be a journey covering areas of device therapy, talking about current management of atrial fibrillation, and then talking about a topic that has become very important to me, and that is the differences in cardiovascular care between men and women and how they differ and what we can do to close that gap. So does this sound familiar to any of you? You go for a stroll and you get out of breath. You go to check the mail, which should be a simple task, and it becomes a big task. Or you're gardening and you're feeling dizzy. Well, it is true that we may slow down when we get older, but sometimes this may not be normal, and this may be a sign of a heart rhythm problem. Aging is inevitable. We all know this, but it doesn't mean that you have to slow down. The normal heart rate is usually between 60 and 100 beats a minute. A slower heartbeat really translates into major problems. Oxygen can't get to where it needs to go, and this leads to symptoms. People can feel tired, lethargic, short of breath. They may feel dizzy. They may even pass out. And this is all due to the fact that blood is not getting to where it needs to go. And there's a name for this problem. It's called bradycardia. Bradycardia is when your heart rate or your pulse either persistently is slow, less than 60 beats a minute, or intermittently slows down for unknown reasons. Many people ask, well, what causes it? Well, as we all get older, oftentimes our natural pacemaker that we're all born with starts slowing down. And so our pulse slows down. But sometimes it's due to other factors. One could have had a heart attack, and scar tissue can develop. This scar tissue can invade into the conduction system and cause intermittent slowing of the heartbeat. Or it could be due to maybe one of the many medications that we are taking as we get older. A side effect, something that may be reversible, where you take the medicine away and the heart rate gets better. Sometimes those medicines can't get taken away. What age? Well, it sort of isn't specific to a particular age. Patients who get older, it's true, may slow down in terms of their pulse, but sometimes some of these things are unavoidable. We're starting to have heart attacks earlier in life, unfortunately. So sometimes that can cause a problem. Or some of these medications may be prescribed at a young age. So there isn't a number that correlates to the heart rate. Symptoms are the ones that I talked about just a moment ago. Dizziness, lightheadedness, fainting, feeling like you're going to faint. These are all signs of a potential problem with the heart rate. How do you find out if you have a problem? Well, your physician may decide to do an electrocardiogram, an EKG, where wires are placed on your chest and a measurement of the heart rate is created. Sometimes they may place a monitor on you called a Holter monitor. This is a monitor that you wear for 24 hours, and it records each and every heartbeat for that 24-hour period. With this recording, we're able to tell, well, how does the heart fluctuate? Because sometimes these slow heartbeats are intermittent and unpredictable. You may feel fine, and then all of a sudden you feel lightheaded, and that's because there's a sudden drop in the heart rate. Sometimes patients have to come in for a minimally invasive procedure called an electrophysiology study. This is something that I do as an electrician. Just like an electrician may go into the wall to check to see what's going on while your light's not working, well, I go into the body and check the wiring of the heart. I take small, tiny catheters, and I measure the electrical signals. And I'm able to tell, is there a problem or isn't there a problem? There's a multitude of ways to try to figure out whether there is an issue with the conduction system. But in patients who have bradycardia, who are symptomatic, there's one solution, and that is a pacemaker. These are devices that are there to prevent the heart from going too slow. It creates a floor. It prevents the heart or the pulse from dipping too low and turns on only when it needs to. You may have heard of things called defibrillators, okay? Now, what's a defibrillator, may you ask? Well, defibrillators are devices that can function like pacemakers, okay? So they're capable of preventing the heart from beating too slow, but they also prevent the heart from beating too fast in an irregular fashion. They're life-saving devices, and their main treatment is for something called sudden cardiac arrest. Now, sudden cardiac arrest is when the bottom chambers of the heart, and we all have four, two on the top, two on the bottom, and when these bottom chambers start fibrillating or quivering, and when that happens, blood doesn't flow well. And when blood doesn't flow well, we run into major problems. The problem that we face in this country is that sudden cardiac arrest is the #1 killer in this country. 450,000 patients per year, on average, die from this particular problem. This is greater than strokes, lung cancer, breast cancer, and AIDS combined. It is such an important problem that nowadays, when you go into public venues, you may notice that aside from just having a fire extinguisher on the wall, you probably see something called an AED. That's a defibrillator, because we have learned that when patients collapse, if they don't get defibrillated, they die. How quickly do they have to be defibrillated? Well, every minute that goes by without getting shocked, your chance of surviving decreases by 10 to 15%. On average, you have 6 to 8 minutes. After 8 minutes, the chance of you surviving is less than 10%. So it is exceptionally important that if you qualify for a defibrillator, if you're at risk for a defibrillator, that one should be considered for one. So you may wonder, what are my risk factors? How do I figure out if I'm somebody who should be considering a defibrillator? Well, if you have a history of a prior heart attack, or if you've had a stent, a scaffold placed into your heart artery that tries to keep the artery open, or if you've had bypass surgery, you may be at risk. Patients who have a weak heart muscle, or what we call a low ejection fraction, which is a measurement of deciding how well the heart squeezes, again, may be at risk. Patients who have a history of something called congestive heart failure, where fluid backs up into the lungs, or if you've had a history of cardiac arrest, you've been fortunate enough to survive one of these events, then you certainly should be getting a defibrillator. But sometimes the symptoms are a little bit subtle. You may have unexplained blackouts, unexplained spells of dizziness. You may feel palpitations that lead to dizziness, but you don't know what's going on, and then they stop. Or you may actually faint multiple times and not know why that happened. These may all be signs of episodes, short episodes, but episodes of this rhythm problem, which can lead to cardiac arrest. Unfortunately, the vast majority of patients don't have any symptoms at all. The first time they show up is when they have their cardiac arrest. And we hope that we're able to save them so that way we can give them this life-saving therapy. So let's just see for a moment what actually happens when you're actually in fibrillation. This is a human heart. And what you see, it's quivering. That metal piece right there is the wire. That's the lead of the defibrillator inside the heart. And eventually what you see is the heart get defibrillated. We're going to see this again. It's fibrillating. That's the lead. It got shocked, and you can notice now restoration of a normal beat. This is what works. This is what saves lives. So you may wonder, okay, talked about pacemakers, talked about defibrillators. How do these things go in? Well, they go in a similar fashion. What happens is that I make a small incision underneath the left collarbone, place the device underneath there, under the skin. 1 to 3 wires comes out of the device and gets placed into a blood vessel that sits underneath the collarbone called a subclavian vein. And that's the road into the heart. Now in this case, this is a pacemaker. So if the heart starts slowing down abnormally, the pacemaker recognizes that and starts sending impulses to get the heart rate back up again. This is done within an hour and usually requires only mild sedation to do. And you're home either the same day or the next morning. So it's not a big procedure. So the question that many of my patients ask when they get one of these devices is, what kind of lifestyle changes am I going to have to make because I have a device that's been implanted? The fortunate truth is that most of the time you can lead a very normal life that hasn't been altered because of the device. So can you lead a normal life? Absolutely you can. So let's just cover some of these pertinent questions that get asked. First, can you go through airport security? Absolutely. You're usually issued an ID card. You show the ID card to the security personnel. They'll take a look. They know exactly what to do. You're good to fly. What about cell phones and cordless phones? Absolutely. You can use those as well. The only thing we ask is try to use the opposite ear just from a pragmatic standpoint rather than putting the cell phone right over the device itself. How about regular household appliances? Am I going to be able to use my microwave? And the answer again is yes, you absolutely can. But I'll tell anybody, even if you have a device or not, probably not so smart to stand right in front of the microwave all the time. Walk away, come back after your food's cooked. Physical activities. Can I do what I was doing before? Walking, jogging, bicycling? Absolutely. One of my patients I just saw yesterday runs marathons. She has a pacemaker, and she's still running those marathons, not an issue at all. One topic that sometimes people are embarrassed to ask about is intercourse. And absolutely, you can have intercourse. The only thing I request is that you talk to your physician first. If it was a new device that was put in, you might have to wait a little bit, but you should be able to carry on. What happens with the battery? It is a powered device after all. Well, we monitor the battery in our offices, and we're able to predict when that battery is going to start coming to a low residual value. When that happens, we have the patients come in for an elective replacement. What that involves is not popping out Duracells. We make a small incision, take out the old device, and you get a brand new device. Okay, the whole thing's one unit. The wires have a lifespan of 20 to 30 years usually, so we don't have to worry about the wires. But the device gets replaced. The benefit, you get the latest and the greatest of that day and time. So we're going to switch topics for a moment now, and we're going to move over to atrial fibrillation. Now, atrial fibrillation is something that many of you may have already heard about. What you see here is actually fibrillation described in color, okay? You can just see chaos. Things are just floating around. So what is atrial fibrillation? Well, atrial fibrillation is when the upper chambers of the heart quiver erratically, which causes the lower chambers of the heart to beat irregularly, okay? It is the most common heart rhythm problem in the world. Symptoms include palpitations, weakness, fatigue, decreased ability to exercise. You may feel dizzy. Sometimes patients can even feel chest pain because of the symptoms. And symptoms can be subtle. So sometimes patients may be living with atrial fibrillation and say, I feel fine. But when pressed, it turns out that what used to be a 6-block walk without any issues at all has now turned into a 3-block walk without issues. So you've slowly decreased your ability to do the activities that you normally did. So symptoms can be subtle. Now, what puts you at risk? Well, there's a number of things that put you at risk. Just getting older. 10% of patients over the age of 80 develop atrial fibrillation. So it is a very common problem. Heart disease, valve disease, structural heart disease is a risk factor. Heart attacks are a risk factor. High blood pressure, diabetes, obesity, and sleep apnea. And there's even a genetic component to atrial fibrillation. This basically is showing that today, in 2015, it's estimated that we have about somewhere between 4 to 5 million Americans that suffer from this problem in this country. However, over the next 30 to 40 years, it's projected that the number of patients is going to balloon to 15 million patients. It's tremendous. It's truly an epidemic. The reason? We're living longer, but unfortunately, we're also leading unhealthy lifestyles, which leads to the high blood pressure, the diabetes, and subsequently atrial fibrillation. The issue here, because of this growth, is that the lifetime risk of any individual in this audience of developing atrial fibrillation is about 25%. And I promise you there's probably individuals here already that already suffer from AFib, and unfortunately those who are going to develop AFib as we get older. AFib is a progressive disease. What it starts out as, oftentimes are just short, intermittent symptomatic episodes where you have an irregular pulse that lasts maybe for a couple minutes, maybe for a few hours. You feel the symptoms and then they go away. However, over time, if untreated, it becomes a progressive disease where the frequency of those symptoms will increase as well as the duration. And eventually, it becomes a persistent disease where you go into the irregular heartbeat and then it doesn't stop. And it requires some form of an intervention to make it stop. So the issue is that if left untreated, it becomes a more chronic problem. With that, though, comes other issues. As it becomes more persistent, the heart changes as well. Scar tissue gets deposited into the upper chambers, which makes it much more difficult to treat the problem over time. And about 20% of patients will progress from that paroxysmal or intermittent episodes to a more persistent form in a year's time. So the progression can be very quick in some individuals. When we talk about atrial fibrillation, when I speak to my patients, I worry about two things. I worry about what symptoms you're having and your risk of stroke. AF, or atrial fibrillation, is the leading cause, or is one of the leading causes of stroke in this country. It accounts for 1/3 of all strokes due to clots in patients over the age of 60. And it increases your risk of stroke over 3 to 5-fold. In actuality, especially in women, certain studies have demonstrated that AFib alone, independent of whether you have high blood pressure, or if you're diabetic, or if you've had a heart attack, just having AFib may increase your risk of death in addition to all those other problems. So AFib is a serious disease. Now, why strokes? Well, the reason strokes happen is because this upper chamber here, which is the atria, is quivering, remember. It's not beating normally. If you take a water balloon and you squeeze it, all the water comes out. But if you make a quiver, very little moves. Well, when blood doesn't move, it has a tendency to form a clot, right? Just like if you cut yourself. Now, this clot, unfortunately, will then have the ability to escape the heart. And it's going to travel up the bloodstream, and it's just going to travel along on the pathway, in this case, up into the brain. And it's going to just continue traveling through the arteries. The problem is that as the arteries continue onward, they get smaller and narrower as they're trying to feed different areas of the brain. Eventually, this clot's going to be too big for the artery that it enters into, and it's going to block, and it's going to clog. And when that happens, normal blood can flow forward. When that happens, brain cells die, and you have a stroke. So this is the reason why patients will have strokes. The issue is how do you prevent this? How do you protect yourself against these strokes if you have AFib? I will tell you right now, and I know there's some patients here already who probably have AF, if you're being treated with aspirin alone, it's not sufficient. The reason is the material that makes this clot is different than the material that aspirin prevents from clotting. Aspirin blocks things called platelets, okay? The clots here are formed by thrombin, so it's a different material. So the treatments here are things like Coumadin or warfarin, Or in this case, we've been fortunate in the last 5 to 6 years to have a number of new agents that are on the market now, commercially known as Pradaxa or Xarelto or Eliquis or Savesa. Okay, so there's a number of new agents that are out there, but those are the agents that help with the protection. When we talk about symptoms, there's 2 ways of addressing symptoms. There's a rate control strategy and a rhythm control strategy. Now, what a rate control strategy means is that we have said, as a physician to you, we say, listen, you're doing okay, we're going to keep you in atrial fibrillation, but we know you feel some symptoms, so the way we're going to try to control that is we're going to prevent your heart from beating too fast, okay? And so we'll give you medications, something called a beta blocker or a calcium channel blocker, to try to make sure that your heart doesn't race away. And that may be enough for some patients. In a rhythm control strategy, what we're trying to do is prevent the AFib altogether. And we're saying, listen, we know you're symptomatic from atrial fibrillation. We don't want you to have it. What can we do to prevent it from occurring? And there's a number of ways that we can control the rhythm. Historically, and even today, commonly we'll use medications to try to prevent that recurrence from happening. Something called antiarrhythmic medications, of which there's several types. Amiodarone is probably one of the more common ones that people may have heard about. But there's something called Ticacin or Sotalol as well. These are agents that are kind of like a Band-Aid. They're trying to prevent the electrical disruption that happens in the upper chambers. But it doesn't change anything. It just tries to cover it up. Some patients may have had cardioversions. Cardioversions are a shock, as quickly as I just snap my fingers. You're put to sleep for a couple minutes. The shock resets the heart, puts you back into normal rhythm. But there's nothing permanent about a cardioversion. It's a reset button. You haven't solved the underlying problem at all. But again, in some patients, it may be the appropriate therapy because they may have AFib once every couple of years. And so you say, okay, let me just shock you back to normal and just wait and see how you do. And we'll keep things going the way they are. But nowadays, what's become much more common for the management of atrial fibrillation is catheter ablation, which is a technique in trying to address the underlying problem that's causing atrial fibrillation and then trying to alleviate that problem. So when we talk about catheter ablation, you want to compare it to some simpler treatments. So we look at things such as medications. These 3 graphs, what they're just depicting, are patients who the decision was made to try to control their rhythm. We don't want AFib to happen. Okay, that was the decision because the patients weren't feeling well when they were in atrial fibrillation. And so we said, okay, let's take half of these patients and we're going to give them the best rhythm controlling drugs that we can think of, the amiodarones and the sotalols that I mentioned before. The other group of the patient, the other group, I'm going to give a treatment called ablation. And we're going to watch and see how you do over time. And what has been clear for this study and many others like it is that over time, patients who are given medications tend to have a lot of recurrences. So what this shows, the numbers are small, but basically 16, 19, 17% of patients were still in a normal rhythm, no AFib, after about 9 to 10 months. Whereas if they had an ablation done, over 70% of the patients were still in a normal rhythm after 9 to 10 months after having the ablation done. So the catheter ablation keeps you in a normal rhythm much more effectively than any medication that's out there on the market. So let's talk a little bit about catheter ablation. When we're talking about catheter ablation, we need to understand how it evolved. Where did it come from? If you can recall a few slides back, I'd shown you that colored slide that looked like a bunch of waves crashing into each other. That was atrial fibrillation. So think of atrial fibrillation like the ocean. It's a bunch of waves that are crashing into each other, and then these waves create other waves, and then those waves create other waves, and they're just sort of chaotically beating about. Well, if you were able to calm the waters, how would you do it? Well, you could put walls up, maybe create a dam, and that would still the waters, right? So a surgeon by the name of Dr. Cox thought about that and said, well, I think there's all these waves. How can I calm it down? Well, I'm going to try to put up walls. And so what he did was he actually cut up the upper chambers of the heart. So this is the heart, these are the upper chambers, that's the bottom, and he actually made incisions all along the heart. I mean, not to be morbid, but he sliced and diced it, okay? And then what he did was that he diced them open, and then he stitched it back up. And all those stitches turned into scar tissue, and that scar tissue prevented any of those wavelets from propagating. So this procedure actually was very powerful. 90% of patients who had this procedure didn't have atrial fibrillation for many, many years. So it was a great outcome. The problem is the procedure is exceptionally morbid. Nobody wants to sign up for this, okay? But what it did do, it gave a lot of investigators thought to say, well, let's try to understand this a little bit better. Why is it that this works, okay? And what we realized is that these structures right here, these are called pulmonary veins. Pulmonary veins are blood vessels that drain blood from the lungs after it's received oxygen and dumps it right back into the heart as it's going to go out to the rest of the body. These blood vessels, for whatever reason, have electrical tissue that has grown onto them. But that electrical tissue is not meant to be there. It serves no purpose, okay? But it does grow onto them. The problem with that electrical tissue is that it doesn't follow suit with the rest of the heart. The heart is a programmed army, if you will, okay? There's one general, that's your pacemaker that you're all born with, and then there's a bunch of soldiers that are just supposed to follow orders, and they're supposed to just follow in suit and in line. The electrical tissue here, it's a bunch of people that are going AWOL. They decide what they want to do, okay? They beat to whatever drum they want to beat to. And the problem is that chaos is what leads to atrial fibrillation. So a catheter ablation procedure is a minimally invasive tool, okay? Not the cutting and dicing that we just saw, but a minimally invasive tool which selectively destroys areas of the heart using either heating or cooling. And by doing so, you're able to restore normal rhythm and allow normal rhythm to persist. How do you get there? Okay, so catheters are placed through IVs that are placed in the creases of the legs. And through these IVs, thin little tubes are introduced into the heart. Now, most of the work occurs on the left side of the heart, and there's a thin wall that separates the right and the left upper chambers. So we poke a tiny little hole through that wall and introduce our wires into the left side of the heart. We can see everything under X-ray, and we can use a fancy sort of GPS system that also lets us know where these catheters are at all times. And then we do our work, pull everything out, and we're done. This is an example of the heart. These are the pulmonary veins that I talked about, those tubes that are draining the oxygenated blood back into the heart. And what we're trying to do is prevent this bad apple from causing chaos in the rest of the chamber. Because again, this guy has decided, I'm going to fire to my own beat, and you know what? Like a disruptive child in a daycare center, everybody else is going to follow suit, okay? So we got to get this guy to quiet down. So what we want is to stop the upper chamber of the heart from talking to the pulmonary vein electrically, okay? We don't want the upper chamber talking to the pulmonary vein, and we don't want the pulmonary vein talking to the upper chamber. So how do we go about doing that? This is a patient of mine that I operated on a little while ago. This is a representation of the upper chamber of the heart. The colored structures are those pulmonary veins. The brown dots are each place where I've actually placed a burn. And what's happening, you can see these brown dots are coalescing. Essentially, I'm creating a line. I'm putting the wall up, okay, without cutting the patient. And what you can tell, and I'm going to draw your attention to down here for those of you who can see it, but you can see a bunch of noise, let's just put it, right? There's a bunch of lines here. And then all of a sudden, all those lines disappear. That's when that vein has stopped talking to the rest of the heart, okay? That's the outcome that I'm looking for when I'm doing an ablation procedure, because that has said these veins can't talk to the heart anymore, and the heart can't talk to the veins. They still do their job. They're still able to drain the blood. So you're not affecting their function, but you're preventing the disruption. So I'm not expecting any of you guys to become electricians, okay? So don't get all caught up in this, but there's a very simple message in this picture. And that simple message is, hopefully you can recognize that there's a whole bunch of jibber jabber going on in this middle section here, right? There's a bunch of lines that are fluttering away. But you can see very distinct, much slower lines up on top, okay? So what's happening here? This is actually a vein, one of those disruptive animals that we were just talking about, firing away erratically, trying to cause atrial fibrillation. But this is a patient that I've actually successfully ablated already. The patient stays in a normal rhythm because none of those signals can get out. Okay? That vein is like in a prison. You can't disrupt the rest of the populace anymore because this is doing whatever it wants to do, but it can't influence the rest of the heart anymore. So this is the outcome. This is why ablation works. You're changing the underlying way that the electricity is flowing in the heart as opposed to trying to cover it up with medications. You're altering the disruption. So the outcome that we're looking for, that I hope to be able to achieve for my patients, is this right here. So this is a patient who was given a small little device. It's called a loop recorder, and it was implanted. It's about the size of a AAA battery, actually cut in half, and it slips right underneath the skin. And what this recorder does is it's able to record the heart all the time. This patient was given one because he was having lots of palpitations, and we just couldn't figure out what was going on, why he was having so many palpitations. And so we put this recorder in. And lo and behold, what we learned was he was having lots of atrial fibrillation. All these blue lines that you see up there represent episodes of atrial fibrillation. So he had the kind that was intermittent. It would come and go, come and go. But when it came, his pulse was 170, okay? He felt horrible, all right? And it would last for hours. So sometimes he was lucky and he only had an hour. This is hours on a scale. Sometimes it wasn't. He'd be having episodes that lasted 8 hours, 10 hours, where his pulse is just racing away. You could throw all the medicines at him, it wouldn't work. So he felt horrible. So in mid-February, he came in and he finally had an ablation done. All right? And this was somebody who actually was already on a rhythm-controlling medication. The rhythm-controlling medicine wasn't doing the job for him. And so he came in and he had an ablation done this day right here. And then since then, you can see what the outcome is. No more blue bars. AFib has gone away. Okay? So it worked. So when it works well. Okay? So we have a lot of tools that we use when we're doing these ablation procedures. So when you're out there in the community and you're talking to your physicians, and if you happen to come across somebody like myself, okay, who's an electrophysiologist, who does these procedures, they may talk to you about, well, we have technologies that allow heating of the tissue, or we have technologies that allow cooling of the tissue, cryotherapy. Okay? I will tell you right now, in terms of effectiveness, at this point, at least in 2015, they're equal, okay, in terms of their outcomes. All right? They're just a little bit different in the method by which they are altering the tissue, but they're equal. So we have catheters here that are able to do that dot-by-dot ablation, and I do both. And then we also have cooling technologies, which are like a balloon that sort of surrounds the area, but again, achieving the same outcome, which is to encircle the vein, put up a wall, put up a scar, prevent that vein from communicating from the rest of the heart. And then there's ongoing research. We have lasers that we're working on right now to try to figure out if there's an application for lasers or different kinds of other catheters that may be helping us improve the techniques and the technology for patients who need to be treated. Oftentimes, I will be asked, am I too old to have this procedure done? Remember that earlier on I told you this is a disease that becomes much more common as we get older. So most of my patients, many of my patients are in their 70s or their 80s who are suffering from this problem. From a safety standpoint, we looked at this and we said, okay, if we had patients who are over the age of 80, let's compare how they do with this procedure versus those patients that are under the age of 80. The blue bars represent those over the age of 80, the orange, under. What we can see is that their outcomes in terms of success are the same. Okay? The procedure usually is successful about 70 to 80% of the time. Okay? And if we watch patients over time, whether you're above 80 or below 80, doesn't matter. The durability of the procedure is the same. But most importantly, the risk of the procedure is the same. So patients, in terms of risks, and there's always risks when we talk about heart procedures. So the things we worry about. Am I going to die? Am I going to have a heart attack? Am I going to have a stroke because of this procedure? Am I going to need emergent open heart surgery because something went wrong? Complications happen. They happen in any case, in every surgeon's hands, right? You do enough of these, unfortunately, somebody's going to have an untoward outcome. Fortunately, the risks are low. They're less than 1% typically. If you add up every complication there is, it's probably in the order of about 4%. But it doesn't matter whether you're above the age of 80 or below the age of 80. Just yesterday, I had this beautiful 86-year-old woman who was maybe lucky if she hit 5'2", okay? She had this problem. She's been suffering. She's been in the hospital 4 times because of AFib and her heart going at about 160 beats a minute. And she just couldn't tolerate the medicines. We just did the ablation. She did fine. She's going home today. So it doesn't matter. The question is whether you're a candidate or not. So that's the big question, all right? Are you a candidate? And we'll talk about that a little bit. Let's just talk a bit about quality of life, right? That's what this is all about, right? You want to live a good quality of life that's extended, right? So from a quality of life standpoint, we've actually measured this as well. And we've looked at patients who've had successful ablations versus those patients who were either didn't undergo an ablation or who were put on medical therapy. The higher the bar, the better quality of life. It's not even close, right? So the quality of life is tremendously improved on patients who have catheter ablation procedures. And there's a reason for that. One, it's an effective treatment. And so patients feel better because it works, okay? Two, is that you don't often have to take as many medications when you've had a catheter ablation done versus those that haven't. And we all know that medications come with baggage. They all have side effects, right? Whether it makes you feel bloated or dizzy or swollen or tired or whatever it may be. And the third reason is, unfortunately, the rhythm controlling medications that we have are just not that effective. Probably work about 50% of the time. The newest one on the market, which isn't so new anymore, is a medicine called Motac. That came out maybe about 6 or 7 years ago. We were very hopeful that we would get a medication that would be much more effective. Unfortunately, it was a huge disappointment. So we just don't have great drugs yet that can help manage this problem. So this is the reason why catheter ablation is such a powerful tool. And it's for this reason that in 2014, the guidelines that help govern what I do, okay, changed. Catheter ablation used to be considered a second-line therapy, meaning that if you had atrial fibrillation, you had symptoms, we were obligated to give you medications, medicines that we knew may not work or may put you at risk for other organ toxicities, including liver damage and thyroid damage. But we were obligated to put you on those medications, try them first, and then see if they failed, then you'd qualify for a catheter ablation. But now, catheter ablation has moved towards what we call first-line therapy in certain patients. And so in individuals that meet the criteria, it may be considered as an option, as opposed to having to go on medications. So, are you a candidate? Chances are probably yes. If you have symptomatic atrial fibrillation and have been placed on one of these rhythm-controlling medications, but it doesn't work, you're still having symptoms, you're still having recurrences, or if the idea of taking one of these medications is something that you're not excited about because of either side effects or yet another pill, then you may be a candidate for this procedure. Again, the decision is on an individual basis, right? It's patient-specific. But most patients are often candidates for this particular position. So the last thing I want to talk about is the differences, right? How do we perceive ourselves and what happens? Yeah, enough said, right? So there is a difference, okay, between the perception of heart disease and the reality of heart disease. The perception is that Caucasian men tend to be the ones who have the highest risk of coronary disease in the country. The reality is that heart disease affects men and women equally, and that it doesn't matter what race or what ethnicity you are. The big important truth is that it doesn't matter if you're an African American woman, if you're a Caucasian woman, or if you are a Hispanic woman. Your risk of heart disease is as great as or greater than your male counterpart. This is humbling. Heart disease is the #1 killer, we know that, but it's greater than the next 5 in line combined. Okay? 1 in every 3 women who die often die from heart disease. And it's estimated that nearly 500,000 American women are dying from this problem every year. So it is a large and powerful statistic. We all know, or we may know, what the typical signs of a heart attack are. The crushing pain right here in the center of my chest. It's moving to my left arm or my jaw. My left arm is starting to have pain. My shoulder is starting to have pain. Those are the typical symptoms that we experience. But women many times will experience more subtle or atypical symptoms. They may just have shoulder pain or isolated neck pain or jaw pain, not the chest pain that we all know. They may experience just shortness of breath. They may just have flu-like symptoms, or what may be described as flu-like symptoms. I'm feeling tired. I'm feeling cold. I'm feeling nauseous. And you go to the emergency room and they say, well, geez, you might just have caught a bug. Okay? You may feel anxious or weak or tired. And these are symptoms that are atypical, but may also represent symptoms of heart disease. The problem is that women today in this country still perceive cancer as their number one threat. Okay? That is their biggest fear when polled. Women today oftentimes will say, well, what's the number one killer? Cancer, breast cancer, right? But the truth is that cancer doesn't even come close to the number of patients that are dying from heart disease in this country. What we've seen from 1997 to 2003 is that the awareness of heart disease as being a killer has not changed much. And if I were to extrapolate this down to 2015, it hasn't changed much either, unfortunately. Awareness in the community, clinicians, nurses, doctors, so forth, it's improving in terms of understanding that heart disease is a killer, but it's not great. Okay? We're still not appreciating this. And it's because of this that women, oftentimes, when they have some of these subtle symptoms, will go to their primary care doctor or their OBGYN. But your OBGYN may not have heart disease as their primary thought. So it will get missed because the awareness is not there. And the patient may not recognize the importance of pressing the issue. And now you have a patient who has heart disease, but it's not getting the treatment that they deserve. So it's in these situations that women get underserved. They may not be referred for stress tests as often as men are because the thought's not there to worry about it. Or they may have had a subtle finding on the stress test and they may not get referred for the cardiac catheterization, which is a procedure that looks to see if there's actual blockages in the heart arteries using little tubes. The physiology of heart disease in women is different as well. And that may explain why some of the symptoms are different. Women tend to have narrower blood vessels that service the heart, and the plaque that builds up in these arteries, the blockages, tend to be sort of diffuse all along the artery. Whereas men, when they have plaque buildup, oftentimes it will be a discrete lesion that's very tight. So a man may, for example, go from having good blood flow to all of a sudden saying, oh my gosh, I don't have good blood flow at all. That's why I have this crushing pain. But a woman may have diffuse progressive disease, so the symptoms are subtle and progressive over time. And that may be one of the reasons why we're missing this. So an interesting study was done, and this was actually eye-opening for myself. The question was, does race and/or sex affect physicians in terms of their recommendations for a simple procedure called cardiac catheterization that I just mentioned before, the test to look to see if you have blockages in your heart arteries? So what did they do? So they took 720 physicians, and they presented them with pre-recorded interviews that were done, scripted interviews by actors posing as patients. And these interviews were then viewed by these physicians, and they were given additional data. And then they were asked the question, does this patient need a catheterization or not? What they found was that African Americans and women were much less likely to be referred for a procedure that was indicated than men and Caucasians. What's really interesting is that it didn't matter whether the physician was a man or a woman, or if the physician was Caucasian or African American. The bias was all the same. So this is pervasive in the clinical community. It's not about who you are or what you are. It's just unawareness of understanding the importance of heart disease in women. Okay, and this is what we're trying to hopefully change. This translates into my world, the rhythm world. Okay, so this was a study that looked at 900 patients approximately. 47% were men, 53% were women. And these were patients who were referred for a procedure, a type of an ablation, okay, what we talked about just a moment ago for atrial fibrillation. But this was for something called an SVT, which is a very common short circuit that can exist. And what they did was they looked at their patients that came in through their doors, and they said, okay, what's the story? What are the differences between our patients? Well, women were often referred much later than men were. They tended to be more symptomatic than men were. They were tried on many more medications before they made it through the door. And the question was, why? Because the outcomes are the same. The patients have equally good outcomes, 97% cure rate, so they both did well. They have the same risks. The complication rate is less than 1% in both sexes. So why? Why was there a difference? And then they postulated, they wondered, and they said, well, some women were told that they had anxiety disorders. They weren't diagnosed correctly, so it took a while, okay, because they said these palpitations are because you're anxious. Or women themselves were fearful. They were under the perception that their complication rate was higher with this particular procedure than their male counterparts, which is not true, but that was the perception. So there's a difference out there, and it's been translated into real world. If we look at patients with atrial fibrillation, a similar problem occurs. This is 220 patients that were studied. Now, the first glaring difference is right here. 70% of the patients were men that were referred for the atrial fibrillation ablation. Only 22% were women. Why the discrepancy? Because the truth is, AFib doesn't discriminate. It affects men and women equally. So the rate of atrial fibrillation is the same in the population, but the people who get the treatment differ. The referral rate is different. The women that made it to the center tended to be older, tended to have symptoms longer, tended to have progressed along that spectrum that I showed you before, from paroxysmal to the persistent. They were left in atrial fibrillation longer, and as a result, their heart chambers had gotten a little bit bigger because they were in AFib for a longer period of time. But the outcomes were the same. Their risks are the same. Their successes are the same. So there is a bias in the community. So the message I want to leave to you today is that be aware. If you have symptoms and you're a woman, okay, be aware of the treatment that you're getting, because it may be, and this is not through any malice of any clinician, it's just not being alert and thoughtful and understanding that heart disease can be the problem and looking for it. So in conclusion, you may benefit from pacemakers or defibrillators, depending on your clinical scenario, related to the conversation we had a little bit earlier today. So, if there's a question, probably the best person to talk to would be an electrophysiologist, someone like myself or an electrician elsewhere in your community, because we're the ones who look for these clinical signs before deciding whether these devices are helpful. In 2015, the most effective treatment in trying to manage atrial fibrillation is catheter ablation therapy. And so it should be considered as part of your treatment paradigm if you're having a conversation with your physician and you suffer from the disease. And finally, it does matter if you're a man or a woman. Make sure, women, that if you have symptoms and your practitioner doesn't seem to be getting to the bottom of it, and these symptoms are symptoms that I just discussed, consider getting a second opinion, because we may be missing heart disease. So, you guys may be wondering whether or not we've settled in. We've settled in just fine in Jacksonville. These are my kids on July 4th weekend. We love it down here. Thank you very much for your attention.